All right, guys, here we go. We're going to try this video thing. I'm not actually going to stand. I'm actually going to go ahead and just do the PowerPoint and talk to you while we're going through the PowerPoint itself. It says chapter 20. This is actually chapter 22 in your textbook. Should start on page 949 roughly. And here we go. All right, so immunology. What do you need to know about immunology is the study of the immune system. The study of the immune system, how it works and pertains to us, and how it works for us. One of the big things that this book is preaching is the fact that you're going to be studying about anaphylactic and allergic reactions as far as your medical assessment for immunology. So one of the things that they really want you to pay attention to is you've got cardiovascular collapse. We'll talk about that. And acute airway obstruction. Acute meaning very fast airway obstruction, and it does happen. You also have very acute cardiovascular collapse as well, and I'll explain to you what that means as we go on. All right, so you're supposed to be able to recognize the stuff, figure out what it is. We're going to teach you the signs and symptoms of what it takes and what you need to know. First thing we're going to do is review some A and P. Basically, your body is set up to fight off foreign invaders. You have foreign invaders, what they call foreign invaders, all the time. You've got viruses, like the new thing with the coronavirus. It is a virus. It is invading the body. You can also eat food. You bring food into your body all the time. That is not technically foreign invaders, but it is foreign. And it's all in how your body reacts to it and the way it sees it as an invader or not. So on every cell that you have, there's these little markers. And here what they're saying, this little pink one that they're showing is a representative. What it is, it's a self marker. It basically identifies it as self. It says, I am you, don't attack me. And what it's referring to is the white blood cells. In your bone marrow, that's where you have these stem cells come out. And these stem cells, based on what the demand and what the need is, will actually specify out into a specific type of blood cell. You got your red blood cells and your platelets. That's fine and dandy. Red blood cells are transport the oxygen on hemoglobin. Platelets are used for clotting. But all the rest of these cells specify out into our immunity. They are white blood cells. If you remember the picture that I've showed you before, red blood cells, plasma, and then there's a little thin white line of white blood cells, and yet there's so many different ones. And we're going to talk about a few of these and what they do. So the first, we're going to define something called an antigen. An antigen is any foreign subject that's introduced to the body that causes an immune response. Basically, it's like somebody coming in and breaking into your house, and now you're going to set your body on high alert. Part of what your body does is it makes antibodies to these antigens. And what it does is it has these little antibodies are made. And these antibodies have on the end of them the key marking system. If you'll see like these right here, they're locked in. They've actually got a hold to them, and they'll get rid of them and destroy them. So the whole key is to try to make antibodies for every single thing that you can do. Believe it or not, or you could have any kind of virus that you can have, any foreign antigen. Believe it or not, you can actually do this. It is very capable, or your body is very capable of doing this. It is able to set up and make hundreds of thousands of different antibodies, and it does so without even batting an eye. There's two different ways, or they call it cellular immunity and humoral immunity. If we go back, we look at you had T cells and B cells on that slide. If you go back and look at it, you'll see there's on the side on that slide, there's T cells and B cells. Basically, you've got the T cells. They're manufactured in the bone marrow. They actually destroy the invaders themselves. They'll actually attack the viruses themselves. The B cells will the B cells will make the antibodies that will attack it. The T cells will attack it itself. The B cells will actually go ahead and make the antibodies. They're responsible for making the antibodies. So you have the T cells that attack it directly, and the B cells that make the antibodies that attack it indirectly. And that's what it basically boils down to. The B cells will attack it from the outside the T cells attack affected cells. Why are we attacking infected cells? Well, basically what happens is you have a virus come into your body. It will find a specific cell that it likes. Some are specific, some are not. It will actually inject its DNA into the cells. Inside the cells, it'll replicate and start using the energy of the cells and any of the proteins in the cells. And it'll actually use up whatever's inside the cells and use it for what it needs instead of actually what the cell is supposed to do. So it'll start replicating itself, building, and then it'll bust and release, and you'll have more new viruses. So the idea is to try to attack the virus itself from the outside, and then you may have the infected cells try to get and defeat the infected cells before they release these actual other viruses. So you've got two processes, one to attack it by itself and one to attack the infected cells. Now, there is something called HIV. All of you, I'm sure you've heard of HIV or AIDS. The bad part about AIDS is the virus itself attacks the white blood cells. It attacks the cells that are supposed to be defending you. It's literally like attacking an army and destroying an army with a bunch of undercover agents and taking out a whole entire army that's supposed to protect you. You wipe out the army, then any other invader can come in and attack you for no reason. And that's exactly what happens in the case of AIDS. White blood cells are destroyed by the AIDS virus. Then you get the common cold or pneumonia or something else that attacks you, and then it's game on. So you're left with no defense whatsoever to actually protect yourself. So you can't really see this slide too well. It's a little blurry, and I apologize, but they talked about the way that we actually acquire our immunities, the way that we actually can make antibodies, and how it's done. So there's two ways. Actually, there's four ways, but there's two different ways that we acquire them. One is naturally, and one is artificially. Naturally, it's called naturally active. Our naturally active immunity, how acquired immunity, is basically we actually get sick. The virus invades us, we get sick, and we're able to build the antibodies from that. The way that we get it passively, it is passed along. That's how I remember passive. It's passed along. You just take it and pass it along. Naturally passive is when we are actually newborns or when we're still in utero. And we're a baby inside, we still got the placenta, we're hooked up by the umbilical cord. Our mothers are making antibodies that are passed on through the bloodstream, through the placenta to us. And we actually have that immunity even after we're born. And we'll carry those antibodies for a while until we're forced to make our own, which is when we get sick. You can also get it from mother's milk as well. So even after you're born, you can still have it from mother's milk. Artificially acquired actively is to actually give us dead virus. That's what our vaccinations are, typically. Most of them are dead virus. Some actually have some live virus in them, but some are actually really just dead virus. And what happens is your body finds them, your immune system finds them, makes the antibodies to fight the dead virus in case you are ever introduced to the live virus. So it's already had the antibodies made. The passive way of doing this is just to take the antibodies and to literally just give it to us artificially. Just inject the antibodies, not have us actually make the antibodies from having the dead virus put in us, but actually just give us the antibodies themselves. That is possible to do. So what we're really concerned with now for our chapter and for our intensive purposes are whether or not we're going to have an allergic reaction and how bad it is. Obviously, it's caused by the immune response, and really what an allergic reaction is an exaggerated immune response to any substance. It doesn't matter. The body is an odd creature, obviously. It'll actually figure out what it is that it will and will not tolerate, and some people are just allergic to things that are just ridiculous. Some patients you might encounter actually don't know that they're allergic to anything, and they may not understand that they're having an allergic reaction, and they won't understand why they're having it because they haven't done anything different. And maybe they have. The key is to try to find out what it is that they've done different, what they've ate different today, what it is that they've done different. They're taking a new medication. They're doing something different today that they don't normally do in their everyday lives. They've introduced something to their body differently than what they've done before. So you have an allergic reaction, which is exaggerated, an anaphylactic reaction, which is severely exaggerated. And we'll talk about that as we go on. I just want you to know that there is an allergic reaction and there's something called anaphylaxis. So as you start off, you have some mild reactions. Usually if you're going to have an allergic reaction, you'll have some of these minor. On top of this, if you're going to have a severe allergic reaction, typically an anaphylactic reaction, you're going to start having these issues here. So we're actually going to get into these, but I just brought these in to start with in case you wanted to look at the slide itself. So here's the cool thing. The first time you were ever exposed to an allergen or an antigen or whatever, you can usually either eat it, take it, do whatever, use it, take a medication, eat the peanuts, eat the shrimp, and your body first just handles it the first time. Once it handles it the first time, it goes on to high alert. And it says, wow, I don't know what that was, but that was bad. Glad we handled it. But next time it shows up, oh, it's game on. Next time you show up, putty, whether it be shrimp, peanuts, medication, the next time we see you, we are going to go buck wild crazy. We're going to party and throw down. We are not going to tolerate you, period. You are gone. And what happens is you have this, on the second encounter, you have the severe anaphylactic reaction. Keep in mind that you may have the second encounter, you may have a third encounter, fourth encounter, and you'll have an anaphylactic reaction. But typically what happens is every time you're reintroduced to it, but the third time, the fourth time, the fifth time, the anaphylaxis gets more and more severe. So keep that in mind. So with that being said, I just said that usually your first time is free, your first pass is free. That is not always the case. Typically, you have the anaphylactic reaction after the first exposure, which is called sensitization. You become sensitized to it the first time, and you get a free pass. There are incidents, what's called an anaphylactoid reaction, where it is not going to be a free pass, that you literally have an anaphylactic reaction the first time it's introduced to the body. So you may not ever get a chance to be sensitized. You might have an anaphylactoid reaction to peanuts, and you never had peanuts before, and then you eat them, or more likely, new medication. You take a new medication, it's got some sort of ingredient in it that you've never had before, you take it, and you have an anaphylactoid reaction. That's not usually typically the case. That's kind of like the rule or of the exception, not the rule itself. So anaphylaxis, even allergic reactions, but a severe anaphylaxis involves multiple organ systems, and it goes very, very, very quickly. And like I said before, every time it's reintroduced and you have another anaphylactic reaction, it becomes worse and progressively faster. So you've got to watch out and be mindful for that. So what happens is, what's really going on is you have something called mast cells. Mast cells are white blood cells. They're in the body. They're usually on the surface of the gut, the lungs, skin, around the blood vessels, which you'll actually find that those areas right there is typically what's affected the most. We're about ready to talk about those here in just a second. It released something called histamine. Histamine, ignore all the rest of the slide, but I really want you to pay attention. Histamine increases the permeability of the capillaries to the white blood cells. And what that typically means is, under normal function, white blood cells are just patrolling. They're looking. They're like police officers. They're just patrolling, looking for things. But if you do have mast cell degeneration, which releases all that histamine, the histamine makes it so the white blood cells can get out. And the whole reason why that's supposed to happen is because you have the white blood cells now coming out of the capillary beds, out of the bloodstream, and trying to get into and attack any of the cells that are infected. Normally, under normal circumstances, that's wonderful. Typically, it's usually localized to one area. You've got a local area of infection. Like if you get a cut on your hand, you'll see the white pus and stuff build up. That's and it's heat. There's heat there. There's swelling. That's mast cell degeneration, allowing the white blood cells to come in and attack that certain target area. But if you have it on a widespread scale, like all over your body, which is called a systemic reaction, it's global, systemic, all over. That is bad juju. You're having it all over your whole entire body. That's not going to work. Some of the signs and symptoms that you'll have. One of the first things you have is you'll have the urticaria, the hives. Usually the raised bumps, skin, redness. It's itchy. They'll usually have what they call, I think, pruritus. You're itching. You just can't stand it. You just feel itchy all over. You've got the bumps and the redness. Usually it's going to start on the trunk. And what I mean by the trunk, it's going to be the abdomen, the back. That whole area around this body is going to have hives, also known as urticaria. They also say angioedema. Angioedema typically really means swelling of the blood vessels. That's not really the case. What it is the skin in the face. And what happens is you get swelling around the eyes, you get puffy cheeks, your tongue will start to swell, and the up under bottom part, up under here, under the jaw, will start swelling as well. So you have this big facial swelling. The bad part about that is that it can actually start blocking the airway. You can actually start having stridor. Also, what it affects is the lungs. Inside the lungs, you'll start having bronchial constriction. It'll start narrowing down. The muscles will thicken up, and it'll actually start contracting down on the actual airways themselves, which can cause wheezing. So you'll start having the wheezing. Another thing that happens is hypotension. You'll actually have the mast cell degeneration will cause vasodilation. So there you go. You opened up and made the container bigger, but it still has the same amount of fluid. So what happens is you've got bottom out blood pressure. Typically, these patients will start actually looking like they're pale, cool, diaphoretic. Another problem that they'll have, or complaint that they'll have, is gastrointestinal dysfunction. I put in the increased gastric motility. With that being said, is that they will literally have diarrhea. I've had patients that have had complaints of abdominal cramping, pain. They feel nauseated, like you're going to throw up, and they actually have had a bowel movement of diarrhea on themselves. They will have that go along with it. So let's back it up, put it all together. So you're going to have the urticaria, the hives, the scratching. You're going to have the facial swelling where they feel like their throat might be possibly closing off. Not only is it going to have the throat closing off and the swelling to the face and the urticaria, they'll start having problems breathing. They're going to start having the wheezing. They're going to not be able to breathe. Their blood pressure is going to bottom out. They're going to look like crap. They're going to be pale, cool, diaphoretic, probably sweating a little bit, and they're not going to be perfusing well. They're also going to be complaining of abdominal pains, cramps, nausea, vomiting, possible diarrhea. Put that all together, that's your classic presentation of anaphylaxis. So, common allergies that you might have. One is shellfish or nuts. And it says it usually takes 30 minutes, along with any oral medications. Oral meaning you take them by mouth. Antibiotics, steroids, it really doesn't truly matter about that, but those are typically found. I've had people take new cardiac meds and they've been allergic to them. But it says 30 minutes. That's a key thing to remember. You've got to remember that you've got your first pass metabolism. When we're talking about taking oral medications in our pharmacokinetics and dynamics lecture, we talked about portal circulation, how there's like a venous return to the actual liver itself. So remember, it takes 30 minutes for the medication to work. Well, with that, it also takes 30 minutes for you to actually have a reaction to that because it's got to go through, be digested, taken, processed to the liver, and then dumped out into the bloodstream. That's why it takes so long to figure that out. If you inject the medications, you can have a systemic global reaction, probably more immediate than had you eaten anything. So it may not take as long for it to happen. Remember, any injected medications where you bypass the portal circulation, basically you're bypassing the liver and getting it out into the bloodstream, it's faster. They also talk about some other common ones like dust, pollen, ragweed, any of your normal like pollen and stuff like that. They talk about chemicals. One of the things you might want to ask your patient is, have they changed soaps? Have they changed not dishwashing, but clothes washing detergent? Are they using a new laundry detergent? Because that can actually do it. And remember, it's not always the first time they happen. So you got to ask, like, hey, have you used it a couple times already? Have you been introduced to this before? Latex is another big one. That's why EMS service has moved to all nitrile gloves. It is latex free. So that's why we don't provide those latex allergies. They talk about insect bites and stings being a big one. This is a big one, especially during the summer, because you've got people out and about now that are out, especially like they've got to cut grass and do things of that nature around the house, or they decide to start moving piles of stuff that have been stored for a while, or they stored it up in the fall, so they're going to deal with it later, and then they're moving piles of junk to take to the dump. Whatever. You've got people out and about because it's warmer and people want to get out. With that being said, that's when the insects are out as well. They give you some statistics. 50 people die a year. Looks like coronavirus has got them beat so far, unfortunately, but that's just some CDC numbers I gave you. They talk about the stinging organism is usually the stinger in the rear, and the insect, whether it be the bee, wasp, whatever, can inject venom from its stinger into the skin directly. Honeybees do typically lose their stingers. They'll sting. When they fly away, it'll come out. Wasps and hornets will not. The reason why that's important is if you have a patient and you're called out to somewhere, and they say, yeah, I was stung by a bee, more than likely you're not going to run the risk of being stung again. But with a wasp and hornets, they do come back and they do look to sting again. They're usually pretty pissed off mad. I don't know if you've ever done it, but I've pissed off wasps and hornets and gotten stung before, and it is not pleasant. Ants, they talk about ants. So if you see marks like this, usually around the feet, the ankles, anywhere where they can get easily access to skin from the ground up, you're worried about the little small blistering. They actually take and will bite and inject venom from the bite itself. So you might actually start off with just the bite itself. I don't know if you can see in the slide here, but you can if you pull the slideshow up. It's just localized right here. Sudden pain, you got some swelling, it'll have heat, maybe localized urticaria or the hives itself, redness, and maybe some localized itching. They say for that, pretty much the treatment is just put some ice. It shouldn't be too serious, especially if it's just really small and really localized. In severe cases, you're obviously going to go back to your anaphylactic presentation. You're going to have the wheezing, the chest tightness, hypotension being the big one, but that's probably causing the chest tightness because you've just made the container bigger, meaning that you have a bigger container, technically now less fluid, less blood supply. So now to be able to get it pumping in and around, you've got to pump it faster. Wheezing, the anxiety, gastrointestinal complaints, stuff like that, the dyspnea, which comes from the wheezing. So you have the classic presentation, probably more than likely. You may have patients that actually have respiratory failure. That comes from, remember, the angioedema, the swelling of the in and around the face. And it may impede and start pressing on the actual throat itself. So it may actually start not forcing it closed, but really unable to get it so where they can get air in. Especially the tongue is filled in the mouth. Imagine that. The tongue is completely filled in the mouth and you're trying to just breathe through your nose and you've got respiratory distress. It's like trying to basically breathe through a straw really quickly. So keep that in mind. And of course, it can end in death. So they talk about your patient assessment. Talk about your scene size up and your safety. Obviously, the safety of it is that if there is any kind of venomous snake, animal, or whatever that's caused this, then you want to make sure that you're not going to be part of the problem. You may have allergies, you may not, but still being stung and being attacked while you're trying to treat a patient is not fun. You're going to have to kind of follow, when you do your scene safety, you got to kind of consider like the trauma and stuff like that and really be mindful. You're going to be staring at your patient. You're going to get your general impression of, oh my God, sick probably. Because usually by the time you get there, they're probably anywhere between 5 and 10 minutes into this, and it goes very, very quickly. So basically try to identify your life threats. Airway and breathing. Again, I go back to the angioedema, rapid swelling of the upper airway. You could probably lose their airway very, very quickly. You're going to have to make sure that you treat and turn that around. We'll talk about the treatment for that here in a minute. They said look for the increased work of breathing. Obviously, if they're having airway constriction or bronchial constriction and they're having the angioedema, the throat's it's twofold, so they're not getting enough oxygen in. Watch for all the things that come with that. They say put them in a high Fowler's, which basically means sit them up 90 degrees. Good luck trying to get any patient that's having a problem breathing to actually just sit there and just sit and be calm and sit in a high Fowler's. They'll usually not want to sit with street belts on them. They'll probably want to lean forward, get into a tripod position. Don't hesitate with your oxygen. If it's bad, go ahead and assist bag them. They might be altered. That's probably going to be your worst case scenario, is that someone finds somebody outside altered, unresponsive, and you're going to have to go ahead and do an assessment and figure out that it is indeed an anaphylactic reaction. Again, with circulation, hypotension, which is going to drop their blood pressure, jack their heart rate up. So you're going to have to worry about trying to figure how to fix that. So they're saying really for treatment, oxygen, prevent body loss, and keep them in a recumbent or a supine position. The reason for recumbent is that they do have any gastric issues and they're going to vomit. At least they'll vomit off to the side and not laying supine, where they'll vomit into their own airway and inhale it. Obviously, your transport position, load and go if they're bad, because if you are just on a BLS unit, you're not going to be able to do most of the treatments that you're going to want to be able to do this for. And when you get into your advanced, you can go ahead and give the epinephrine. We're going to talk about that, and I believe the Benadryl as well. So we're going to talk about that, a little bit of the epi here in a minute. If you can, get a chief complaint, history, present illness, any signs, look for the signs and symptoms. Obviously, I gave them to you. I'll go over again: the urticaria, the hives, the swelling, the angioedema, the gastric motility. You've also got the shock presentation. They look real shocky because they vasodilated, low blood pressure, rapid heart rate, difficulty breathing, the wheezing, maybe even the stridor from the angioedema. All these signs and symptoms, but the big ones are the ones that I just gave you. In your sample history, ask them if they've ever had a severe allergic reaction to anything before. Ask them if they're allergic to anything. Are you allergic to any medications? And this time, I know I usually tell you don't worry about seasonal allergies, but this might be important. Are you allergic to anything, seasonal allergies that they could be in and around? Be mindful of any statements. Like if you're at a seafood restaurant and like, yeah, I was just having shrimp. I don't usually eat shrimp. They may haven't had shrimp since they're a teenager or a kid. Now they're older in their 40s or 50s. They remember enjoying it. They're somebody special or just something they don't normally do. So be mindful of that, because I promise you, I know people that have taken Benadryl, a big dose of Benadryl. They have an EpiPen. They shot themselves with the EpiPen beforehand. And then they went to go eat at Red Lobster shrimp just so they can eat the shrimp. It's kind of crazy, but people do that. It's kind of like the diabetics that load up on insulin because they know they're going to eat a bunch of sugar. People do it. They're crazy. If you have, especially an unresponsive patient, a head-to-toe assessment is a good thing to do. Expose your patient. Hopefully you'll start carrying shears. You'll cut your clothes. Look for the urticaria. Listen, breath sounds, see if you hear wheezing. Obviously, you're going to be looking at their face. You'll be able to see the angioedema. Look at their skin. Are they pale, cool, diaphoretic? Are they cool to the touch? Do they have a rapid heartbeat? Is their blood pressure low? Putting that all together right there should give you an idea that they probably got some anaphylactic reaction. Your baseline vitals, like I said, you want to see if they're hypotension. Skin signs may be unreliable. Hopefully, if they've got the rash going on, it may be possible that they don't, but more than likely they will. Especially, it's going to be trunkal. It's going to be mainly on the trunk of their body, their abdomen, their groin area, probably on their chest, on their back, stuff like that. Monitoring devices. SpO2, they'll tell you that, yeah, hey, that works great, but it's just a tool to help out with your reassessment of their airway patency, making sure they still have a patent airway. Watch their work of breathing. Are they getting better? Are they getting worse? Listen to their lung sounds. If they seem like they might be a critical patient, it's every 5 minutes. Listen to see if they had maybe a little bit of wheezing. Oh, now they got a lot more wheezing. Okay, maybe it's time that you have a paramedic partner, an ALS intercept. Go ahead and give like an albuterol treatment or do an Duoneb treatment, stuff that we'll get into, we'll talk about later. Again, reassessments. One of the things that you need to watch for is the anxiety level. If a patient, I will tell you, and I thought it was a joke when I was going through EMT school and paramedic school until I got out, and I actually saw people with a sense of impending doom. You have the patients like, am I going to die? No, you're not going to die. I mean, you can't tell them no. What you can say is, it doesn't seem like it based on what I'm finding. Your vital signs are stable. You're fine. You seem like you're probably just really anxious. But if you've got somebody that their heart rate's up, blood pressure's low, they're having a hard time breathing, and they grab you by your clothes and say, please don't let me die. Please don't let me die. I'm going to die. That's called a sense of impending doom. I've seen it. It's actually very, very scary. And I've had people actually physically die that we've got back, but still. Watching your signs for shock, pale, cool, diaphoretic, watching your blood pressure, see if it's trending down, if the respiratory rate's kicking up, if you start hearing an auscultating adventitious sounds, like you could actually have audible wheezing. You can hear it. Like you don't have to listen to it with a stethoscope. You can sit there and listen as you walk in the room and hear them wheezing. It has happened before. You just want to make sure that the reaction's not getting worse, especially if you've done any interventions. If you're not able to do any interventions, rapid transport, get them close. Just make sure you're not going to lose their airway. If you are, try to get an ALS intercept if that's possible. It all depends on the service that you work for, what you can and can't do. They talk about your communication and documentation. My communication is communicate to the hospital, communicate early, let them know you're coming with what you've got. And the things that you need to do there as far as documenting is just document the urticaria, where you found it. We're actually going to start working on documentation when we get back. All right, so yes, all the things we just said. If it is a stinger, if they are stung by an insect, one of the things that you can do is take a credit card. Do not use tweezers or forceps. Take a credit card and slide it along and try to get it to pull out. It'll catch the stinger, bend the skin down enough where it'll actually drag across, and you'll pull the stinger out. Just be careful where the stinger goes. Try to make sure it goes on the ground or wherever, just not where it's going to re-sting. Because if you leave it in and you are trying to treat the anaphylaxis, it's not going to work because there's still poison or venom on the stinger itself. So therefore, it's not going to go away. It still have venom there. So what you're trying to do is block the venom out, but there's still some on the stinger. They say wash the area with soap or an antiseptic if possible. The one thing I will tell you to do is remove jewelry, especially from an affected area, especially if they're going to get swelling in their hands. Take that off, because that jewelry, if it's a bracelet, it's a ring, whatever, is going to impede circulation and blood flow. And there you are having to try to figure out how you're going to cut that off and try to get it off. We do have ring cutters on the ambulance. It is possible to do, but let me tell you, I've used the ring cutters several times. It is not a pleasant thing to do, especially when you already have the swelling in place, because you have to usually cut it. Well, when you cut it, it makes it so it's a sharp, jagged edge, and then it indents in, and now you've got to come over across on the other side and cut out the other side. Well, now you're just taking that indentation and you're pulling it into the skin. It hurts. So let me tell you, it's not pleasant. So if you've got jewelry on, get it off, and get it off early. They talk about make sure that, I guess what they're trying to say here is that if they've already got some airway swelling, make sure that they're not going to build it into a severe anaphylaxis, but you're going to know. You're going to know if you have anaphylaxis or not. You're not going to just have like, oh, it's kind of allergic reaction, then boom, anaphylaxis. I'm telling you, by the time you get called out, these patients and these people who typically know that, yes, I'm allergic to bees, I've been stung before, and yes, I've had to get a whole bunch of medications to try to reverse it, like in the ambulance. Yeah, it's horrible. So, Epi is the drug of choice, especially when you have the difficulty in breathing. That for me, and as a paramedic giving medications, I'll give the Benadryl, I'll give the Solumedrol, which is a steroid. I'll give the breathing treatment if they kind of say that, yeah, I'm kind of a little short of breath and they got a little bit of wheezing. But when they start feeling like their throat is closing, like I feel like my throat is closing, that is when I go ahead and use the Epi, because the Epi's got some bad side effects to it, but you'd rather have the side effects than the actual throat closing. So that's usually that's for me. I'm not saying that's when you're supposed to give it, but for me, that's usually when I look to give it. It's one of the last drugs I look to give, especially if I'm sitting on the fence. But if you do have severe anaphylaxis, it's the first drug I will give because it does so much. Usually they come, as far as what you guys will be able to do in the field right now, as basics, you'll be able to go and use the EpiPen. Typically, people who have anaphylaxis or an anaphylactic reaction to something, they usually keep the EpiPen with them. Let me back up on that statement because they're supposed to. They're supposed to have it. Most people are like, yeah, I can't. I just, like, some women are like, I don't want to carry my purse. Guys are even worse. They're like, yeah, I have nowhere to carry it, so I just don't. I used to keep it in my car. Another thing or an excuse you'll find is that the EpiPens, they are expensive. No lie, no doubt. They are expensive, especially for some people, and let's face it, in this world, do not have insurance. So the EpiPen is expensive. So they buy it the one time and it expires. And so they'll throw it away instead of getting another one. Or they won't get another one, period. They'll just keep the old one. So I'm not saying that it's right or wrong that if they have an expired one, you could use it. I'm just saying that if it's all you got, then that's all you got. I'm not saying that I will say, yes, it is probably wrong to do, but if it's all you got, fine. So with that being said, you're going to encounter people that should have EpiPens that don't, and there are some that are actually good. I've found more often than not, they don't have them. That's one of the EpiPens look like. It's going to deliver for an adult 0.3 milligrams of epinephrine. It's going to go sub-Q technically. I'm not sure if the needle goes IM. It should be sub-Q delivery. For an infant or a child, it gives half the adult dose, which is 0.15 milligrams. Sub-Q dosing. It's in the EpiPen. It is an auto-injector. It was one of the things we're going to do in lab. We will do it in lab. Hang on a second. My phone is telling me it's dying. So hopefully I'm almost done. The side effects with it is you get high blood pressure, which if you've got vasodilation and you've got hypotension, high blood pressure, you're kind of wanting to have the high blood pressure, but it can go above and beyond. So one of the things is you need to be careful of. You're going to increase the heart rate. The heart rate's already jacked. You'll have some chest pain, some headache, nausea, vomiting. So there's some vicious side effects with this. Again, I go back to what I was saying before. Don't give them the patients without respiratory compromise or they don't meet criteria for anaphylaxis. Be very careful giving the epi. Once you give the epi, you can't take it back. Obviously, any drug you give, you can't take it back. But epi's got some nasty side effects. But it is a good drug and is a much needed drug if the occasion arises. All right, that's all I've got. I'm going to try submitting this up, and hopefully, if you guys got any questions, you'll message me. Thanks. Bye.